should hopefully be an enjoyable session. These are obviously talks that are largely, science-based, but it's really meant to be a conversation, an ability to sit back and sort of take in a lot of information that at the end of the day, the goal is to get you better, to get your family or friends better, and to help you navigate the very complex patchwork of health care that sort of informs, our U.S. landscape. So, this is, and these disorders are the epitome of what I tell patients, are disorders that fall in the cracks in the health system. And so you have to be your own best advocate. You have to, understand the nomenclature, but also be able to navigate the system in a way that obviously respects, physician expertise and sort of allows for the specialties to do their thing. So it can be rather complex for a patient to navigate. With that said, this is again going to focus on a subtype of dysautonomia, specifically what pertains to mast cell disturbances. These are my disclosures. I do a lot of work in autoimmune neuropathy, GBS, CIDP work, but dysautonomia is something that I sort of stumbled into, as Lauren mentioned during my fellowship at the Mayo Clinic in Arizona. I was very fortunate to work with Brent Goodman, who's really a major mentor and friend till this day, and I really got intrigued by this role of mast cell disorders in autonomic disturbances. I know there's obviously a lot of questions, and I just wanted to put this out so that I don't do any disservice to patients. Our clinic is not, unfortunately, not currently accepting POTS patients for reasons beyond my control, but that does not mean that we are not available to help inform and educate, and this is precisely why we're here today, to empower you to reach out to physicians that are well versed in the space, be they cardiologists, neurologists, allergists, to be able to navigate the system in a way that gets you better. And the good news is, even though it's not perfect, there's a lot of points of entry through which you can improve. Our autonomic lab, though, at the university is accepting and seeing POTS patients and helping advance that diagnostic journey. Okay, so for today, our goals are as follows. I'm not going to talk about dysautonomia too broadly. I'm going to focus on mast cell diseases, specifically within the broader context of dysautonomia and POTS. I want to highlight that not all mast cell disorders are the same, as many of you know. And I want to really highlight the subjective mismatch in symptoms and autonomic disease burden, as has been shown by other investigators, as was shown by our recent work. And really the major stimulus for today's talk is work that I undertook with one of my allergy colleagues, Dr. Jem Aiken, at the University of Michigan, who's really an international thought leader in mast cell disorders. And so I think it was a very fruitful collaboration between a neurologist, myself, and an allergist. So I need not show this slide, but I still put it just to orient all of us. Again, this is an excellent illustrative diagram from Dysautonomia International on the right, shown in the video, which is a wonderful video. I show it to all my newly diagnosed POTS patients just to understand the breadth of this disorder. We sort of codify POTS, of course, as being this tachycardic response, often exceeding 120 beats per minute, different from orthostatic hypotension with a disproportionate female to male ratio. I think the official figure is 5-to-1. I took the liberty of adding a 1 to say it's 15-to-1. I really think it's somewhere in that range in my experience, but I don't know what the official statistic is. Really a disorder of young, otherwise healthy women. So when you see a young, otherwise healthy woman with what you may say is an autoimmune profile or sort of joint hypermobility and mast cells, we'll talk about something to think about, often preceded by infection, trauma, pregnancy, and sometimes vaccination. So very interesting condition. Again, I was exposed to this in fellowship, working with Dr. Goodman, and really got intrigued that we don't know nearly as much as we should, but that also there's sort of this perfect storm of so many difficult to quantify conditions coming together that we just cannot measure that well. And so that's sort of the challenge, but also the intrigue of dysautonomia and specifically mast cell diseases. this is a really nice slide. I encourage you to read this position statement. I believe that was put on POTS from the society that looked at sort of the different putative pathomechanisms underlying POTS. Obviously, there's many, looking from impairments in the renin-angiotensin system to hypovolemia to mast cell, which we'll talk about today, to excessive central sympathetic drive, to autoimmunity, to connective tissue disorders. So we'll really focus on MCAS for today, or mast cell disorders, as being one out of multiple mechanisms of action. So why is this important? Well, if you've been following the literature, there's been a lot of publications focused on this interplay between mast cell disorders and dysautonomia. This is a really nice review from I believe it was a silver edition on POTS, commemorating the sort of 20th anniversary of its formal codification, of which I believe Lauren was one of the editors, guest editors of the edition, and it really looked at sort of multiple domains of POTS, of which mast cell activation was highlighted really nicely in this review. We have the really seminal paper from, I believe, 2005 now, from Chabot and colleagues from Vanderbilt, looking at the hyperadrenergic POTS hypothesis in mast cell disease. And I think this paper really, more than any, helped sort of stimulate a lot of discussion and interest in the space. But then you have work done on the other side of the fence, right? So we often have this sort of false sort of dichotomization, right? If you're a neurologist or cardiologist, you publish in specific journals. If you're an allergist, you publish in specific journals, but very little crosstalk, unfortunately. And so on the allergy side, they've also looked at this. So Jonathan Lyons and others have looked at elevated tryptase and its implications for dysautonomia. And then my colleague, who's a senior author here, Jem Aiken, really a leading allergist in the space, he also has done a lot of work both in codifying the diagnosis of mast cell diseases and then capturing symptom deficit. So I think a lot of interest has been sort of already generated in a lot of publications. Again, for most of the audience, I think when you talk about mast cell activation disorder specifically, it's a very specific condition that is really codified by these three main diagnostic criteria. So typical symptoms. Number two is lab abnormalities during flushing in particular. So elevated urine N-methylhistamine, elevated 2,3,11 beta prostaglandin, or elevated serum tryptase above baseline. And thirdly, response to mast cell therapies. Now, those symptoms can be quite myriad in their nature and quite similar to POTS, anything from flushing to palpitations to sometimes fainting to dyspepsia to lots of other things, okay? Often they can have explosive diarrhea, post meals, interstitial cystitis, the list goes on and on. I would also say that, there has a lot of been interest generated by this paper from, again, really quite an impactful paper from the Vanderbilt group that looked at the mast cell hypothesis underlying hyperadrenergic POTS. Again, I'm not going to go into the details for the sake of time, but most of us know that POTS is generally sort of broken down very nicely into hyperadrenergic, neuropathic, and hypovolemic types. These are not discrete, separate entities, but there's a lot of overlap. But I think there's a lot of credence to this hypothesis and this really framework that many of the patients that have the hyperadrenergic phenotype have mast cell disease. And these are patients, for example, that have a hypertensive response to tilt. They might have the sort of stage fright phenotype, feeling jittery, tremulous, on edge. They might respond really nicely to beta blockers or sympatholytics like clonidine patches or to ivabradine, for example. And, this study sort of showed that essentially patients that had the POTS and mast cell phenotype as compared to POTS alone had an elevated phase 4 on the Valsalva, suggesting a hyperadrenergic phenotype. Those that had orthostatic hypotension and mast cells similarly had elevated levels of urine N-methylhistamine. And, they diagnosed this hyperadrenergic phenotype also based off of supine versus standing catecholamine ratio. So what's important here is the definition of mast cell activation was codified using an elevated urine N-methylhistamine during a flushing event. Okay. And as we'll talk about, this is part of the challenge of mast cell is there's a lot of different biomarkers and a lot of different criteria and a lot of false negativity because of sensitivity issues. So, the field is very challenging to sort of quantify mast cell specifically. In addition to, of course, having patients that may have other mast cell disorders that are not specifically mast cell activation. So just a really important paper. If you haven't really read it or come across it, I encourage you to sort of laid the groundwork for, I think, a lot of the work and interest right now. This is a really nice diagram from that paper that's been really presented at multiple sessions, conferences. I think one of the best diagrams kind of very simply illustrating that we have mast cells that we believe are excessively degranulating and releasing histamine, causing flushing, but also causing vasodilation. And as you can imagine, this vasodilation then triggers a sympathetic overresponse, which can then lead to the postural orthostatic tachycardia phenotype. But these patients also have a feedback loop because of increased release of neuropeptide Y and neuroepinephrine, or norepinephrine specifically. Now, okay, this is interesting, but one might ask, well, how many of these patients that we see in dysautonomia clinics, or how many patients through the sort of, in the dysautonomia world actually struggle with this? Well, the answer is I don't think we really have a good grasp. I think that it really depends. Are you starting from a mast cell diagnosis and working to diagnose dysautonomia or POTS, or vice versa, starting on the dysautonomia and POTS side and working to diagnose mast cell? I can tell you that our allergy colleagues, sort of on the other side of the divide, when they've surveyed patients who have confirmed mast cell activation syndrome or mastocytosis, almost 3 out of every 4, which is really a huge number, had lightheadedness daily or occasionally, right? Not a typical allergy symptom, something we might associate more with dysautonomia. Okay. About a fifth had daily fatigue, and about 1 out of every 7, 6 to 7, had a severe abdominal pain. So just something to think about. If you start with a confirmed diagnosis and work towards, symptoms, many of them have, putative dysautonomic symptoms. Now, we of course know that mast cell presents differently from just your typical non-mast cell POTS patient. They have a lot more symptoms that we classically associate with allergy. So I always ask in my review of symptoms in clinic, do you have recurrent ear or sinus infections, lymphadenopathy, dermatographism, urticaria, skin sensitivity? Interstitial cystitis, very common and very suggestive. Recurrent putative UTIs without bacterial growth. Explosive diarrhea, specifically if they've had a meal, feeling very bloated and gassy, having to rush to the restroom. Food intolerances, histamine-rich food intolerances in particular. They might have eosinophilic GI disorders. I believe I watched one of the really excellent sessions from the Dysautonomia International Conference a few years back, and I think it actually might have been uh, 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 Dr. Jonathan Lyons himself saying that they can often have psychiatric symptoms, unexplained mood fluctuations throughout the day. So really quite a impressive list of seemingly unrelated symptoms. And of course they might have POTS and joint hypermobility. So this is where it becomes really important to not only think about quote unquote allergy symptoms, hives, urticaria, but its overlap with dysautonomia and EDS. And again, you have this mechanism underlying it, and you can sort of see where everything starts to come together. So this was actually a really interesting paper that looked at its GI manifestations. And again, just taking the GI tract, which can often be a source of huge disability, about, again, these are patients with established mast cell activation syndrome. About 50% plus have abdominal pain, heartburn, and nausea, vomiting, right? And about a third to 2/5 have everything from esophageal dysphagia to what we would call irritable bowel syndrome to atypical chest pain. And then about a fifth have diarrhea. So diarrhea is not always present, but when it is present, specifically explosive diarrhea can be very suggestive. Now, what's interesting is when they've looked at duodenal biopsies from patients with mast cell, they have, a marked elevation in as shown here in panel B compared to panel C, of these sort of CD117 positive mast cells. And so it's just showing that, there is room, for example, in patients that may have localized dyspepsia or GI disturbances to work with GI colleagues to really try to isolate some of these mast cell clusters that may not be generalized. That's part of the challenge with mast cell is it's not always everywhere all the time. It may be confined to the gut and thereby prompt or require dedicated GI assessment. I did want to also mention, and this is really important, not all mast cell disorders are the same. So we talked about mast cell activation syndrome. Okay. It's really a episodic flushing sort of or episodic attack-like disorder, okay, that has these diagnostic criteria. But we also have hereditary alpha tryptasemia, which is not the same. This is an autosomal dominant inherited genetic variant present in about 7% of the general population due to excessive gene copies of the TPSAB1 gene that encodes alpha tryptase. So the diagnosis is often uh, triggered, or the diagnostic workup is often triggered by an elevated serum tryptase. So just because your tryptase is high does not mean you have mast cell activation syndrome. Really key point. You could have tryptasemia, and you may have hereditary alpha tryptasemia. And so normal variants should be one copy of, or two copies of a beta, two copies of an alpha, or an alpha and a beta. Aberrancies occur when you have sort of excess of either, right? So you have all these permutations that can lead to disturbances of the TPSAB1 gene. So, for example, you'll sometimes see the nomenclatures alpha, 2, beta 2, sort of implying a certain number of mutations. When we talk about systemic mastocytosis, this is a different condition as well, and this has actually World Health Organization diagnostic criteria. It's it's a clonal disorder. So sort of you could think of it on its way to sort of uh, being almost, I wouldn't say a neoplastic disorder, but an excessive generation of mast cells per se, as confirmed on bone marrow biopsy, that often have CD2 or CD25 expression and often have this KIT D816V gene mutation. And these can have really elevated serum tryptase levels. But again, it has major criteria and minor criteria. And the major criterion is basically this multifocal dense infiltrative mast cells on bone marrow and or other extracutaneous organs with this often the KIT 816 mutation being aberrant is often very suggestive. But what I wanted to really highlight here is that you can have both hereditary alpha tryptasemia and systemic mastocytosis in isolation, or you can have it with superimposed mast cell activation disorder. So it's not necessarily an either or situation. So to sort of address some of the needs in the space, my colleague Jem Aitken sort of worked with colleagues on both sides of the Atlantic to sort of generate this global classification criteria for mast cell activation disorders, really to address this question. Well, if you sort of go back, right, not everyone fulfills these three criteria. I would say actually the majority don't. They might have typical symptoms. They might show response to therapy, but a large chunk of patients simply do not have these lab abnormalities. And if, Lauren knows about my frustration in this situation, what if they don't fulfill criteria? Do we still embark on therapeutic trials? Do they have mast cell? Do they not? What are we dealing with? And so to sort of address this challenge, which was really nice, this working group sort of said, well, what if patients are close to having it but don't fulfill criteria? So they sort of had these other two diagnostic codes that have associated ICD-10 codes and proposed criteria. And so they sort of divided it into mast cell activation unspecified and mast cell activation other. And the key points I wanted to highlight here is that mast cell activation syndrome criteria, let's say the unspecified group criteria, are not necessarily fulfilled. Okay. And patients may or may not respond to drugs targeting mast cells, but at its core, they still have clinical and lab-based signs and symptoms in one or more organ. Okay. And it may be confined to only one organ system. Okay. And so it sort of has this inability to fulfill the three criteria, but also the recognition that symptoms may be confined to one organ, for example, alone. When we talk about mast cell activation disorder other, there is event-related elevation in mast cell specific mediators. Okay. There is response to drugs. But again, the mast cell activation criteria are not completely fulfilled um, for one of many reasons. And this may be that, for example, patients may have an elevated tryptase, but it may not meet that 20% threshold, right? So it's sort of allowing for this lack of fulfillment of biomarker criteria, although there may be suspicion. Okay. So again, very similar but slightly different, but it does allow us to capture some of these patients that are not fulfilling the textbook criteria for mast cell activation syndrome that are probably on the spectrum. Okay. So again, just thinking about it, you have mast cell activation disorders. If you fulfill all three criteria, no problem. You have mast cell activation syndrome or MCAS, and then you can sort of diagnose it as primary, secondary, idiopathic. If you do not fulfill mast cell activation syndrome criteria, you could either be dealing with MCAD other or MCAD unspecified. And the difference really is that with MCAD other, you have confirmation of mast cell involvement. It may not be meeting the biomarker criteria. Mast cell activation unspecified, you're not as certain. Okay, the biomarker or the sort of suspicion is there, but response to treatment may not be there, so you cannot certainly confirm involvement of mast cell. Okay. Now, I will say these can be rather close and difficult to distinguish in practice. For the purpose of our research paper, we actually lumped the two together. But the point is that it allows for this codification of those patients on the spectrum. That's the key point to remember. Okay. Now, I just wanted to highlight from a pathogenetic standpoint, why are mast cells so dominant in the dysautonomic space? And the reason is that they do seem to interact with the nervous system. That Silver Edition review really highlights some of the pathogenesis nicely. I'd really encourage you to read it. And it does mention that there is co-localization at times of histamine and noradrenaline in the sympathetic nerves. They are often found in close approximation to nerve endings. There is sort of this ability to activate, different target neurotransmission and potentially affect pain. And so there's certainly crosstalk between mast cells and nerves. And likewise, substance P, which we sort of associate with pain, right? And CGRP, which is obviously famous for being the target of action for migraine medication, seem to also act on mast cells. Okay. Now, from an autoantibody standpoint, and I know that some research have really sort of focused on this autoimmune role, that there does seem to be some autoimmune triggering of mast cells, and that, and I apologize for the misplacement of the arrow, but that beta 2 adrenergic receptors seem to reduce beta cell degranulation. Very fascinating is that joint hypermobility also seems to crosstalk. So, extracellular matrix stretching literally can induce mast cell degranulation. So you can sort of see how mast cells are sort of this ubiquitous cell that's present both co-localizing with nerves, but also interacting with autoantibodies and also triggered by joint hypermobility. So you can think of it as either an effector arm of the autonomic nervous system, okay, or inappropriately sort of functioning on its own and driving neuronal dysregulation, probably both, right? So I just wanted to highlight, and many of us already know this, but treatment does have a role. So if you do come across a situation where someone has mast cell activation syndrome, confirmed, other, unspecified, I think it would be reasonable at least as a neurologist, as an autonomic specialist, I do treat them with an H1, H2 therapeutic trial, as well as mast cell stabilization with cromolyn sodium, as well as often, and I don't believe it's shown here, but I will often use aspirin for prostaglandin inhibition as well. Now, sometimes you can also add montelukast for leukotriene receptor antagonism. And again, this is I don't look at disagreement or controversy as a bad thing. I think when you talk to allergy, there can be differing opinions. My colleague, Dr. Aiken, and I, we actually have very healthy debate about whether this actually helps patients or not. I believe it does. On the allergy side, again, opinions may differ, but that does not mean that we should not engage and talk, because I think really the way the field will advance and the way patients will get better is if you not only have autonomic neurologists, cardiologists, and neurologists sitting at the table, or allergists sitting at the table, but having all of them sit together and really recognize that, yes, this is a disorder that is real. Patients have disability, okay? And we really need to sort of move things ahead because we know a lot now that we didn't know 10 years ago. But patients are still suffering and patients are still stuck in limbo, not knowing what to do. So I think this is important to sort of talk about more. So this leads us to our research. And so, Dr. Aiken and I talked together a few years back and we said, well, let's look at this. Again, we know there's a lot of association, there's a lot of noise. It's been researched in hyperadrenergic POTS. Let's look at patients that have been confirmed or suspected of having mast cell activation disorders, and then take them to the autonomic lab, administer autonomic questionnaires, do autonomic testing, and sort of see what we find. So, and I believe we'll take questions then, so I'll kind of come to those at the end. So, the major take home of this study was really that autonomic reflex testing does not capture the full extent of autonomic impairment in patients with mast cell disorders. So, many of us know the Compass 31 questionnaire. It's a really well validated, well studied, universally used measure of autonomic disease burden as reported by the patient that covers these different domains that are weighted, everything from orthostatic intolerance to pupilomotor function to the gastrointestinal function and bladder function, etc., sweat function. And really, we found that most of these patients had moderate to severe disease burden. So their scores were well above 20. I believe the median was 40. But their CAS scores or their objective burden was quite mild. I mean, they were scoring in the 0 to 1 range as measured on autonomic testing. So that was interesting. Patients are reporting a lot of symptoms that are not showing up on necessarily formal testing. In addition, we found that patients that had hereditary alpha tryptasemia had CAS scores that were less than those patients who had mast cell activation syndrome disorders. So hereditary alpha tryptasemia does not seem to be as disabling from an autonomic standpoint as mast cell disease. Again, why it's important to separate these two and not just say you have MCAS when your tryptase is high. Again, objective and subjective intragroup differences. So those with MCAS had generally scores objectively now on autonomic testing that were higher than those without MCAS, but they were both relatively mild. Those with hereditary alpha tryptasemia actually had scores that were less at a statistically significant level than those without hereditary alpha tryptasemia. And this was actually irrespective of MCAS. Again, our total cohort size was only 16, so it was not powered, but we did see a statistical difference to significant difference for hereditary alpha tryptasemia. Then COMPASS scores, which were much higher, were high in all of these patients. No differences were seen whether you had MCAS or not, or hereditary alpha tryptasemia or not. So that was another interesting finding. So how does this sort of weigh in the treatment landscape or the existing literature? Well, Jonathan Lyons in his 2016 paper did indicate that there was high COMPASS scores in about half of patients with hereditary alpha tryptasemia, not unlike our study. There was no dose effect of how many mutations you had or how much dose of the mutation you had, whether it was a duplication or a triplication. Now, Dr. Aiken in his 2022 study actually did not see a difference in COMPASS 31 scores when comparing unselected hereditary alpha tryptasemia patients to healthy controls. So, maybe there is no effect at all. Um, Interestingly, there was also no difference when comparing those that had hereditary alpha tryptasemia and mastocytosis to those with mastocytosis alone, without hereditary alpha tryptasemia. Now, Wang and others in 2024 studying about 493 subjects with POTS found that there was no difference in incidence of hypertryptasemia, whether you had POTS or not. So this obviously opens up the question of, are we capturing dis, you know, occult dysautonomic disease burden with Compass 31, or is it simply an exaggeration of symptoms that are really not physiologically there? And this is a major challenge, I think, in the field is, you know, is there potentially selection bias? How much of this is somatization versus true underlying? And so this is really where we need more scientific data and evidence to help advance the field and to help serve patients better. But I would sort of say these points as a take home, which is the ECNM AIM criteria that we used, of 2022 criteria that we used, so sort of looking at MCAS, MCAD other, MCAD unspecified, can be a really useful framework to allow inclusion of patients that are not fulfilling the textbook MCAS criteria to still be part of the discussion, to be part of research trials, to be tried on immunotherapy on therapies, right? And not simply told you do not have MCAS, go away. I think we need a lot more neurology allergy crosstalk to help advance this field. And I think we really need to recognize that autonomic reflex testing is not always sensitive enough for capturing disease burden. There is clearly a fair amount of subjective disease burden that's in excess of objective disease burden that's not captured. And this was also shown in a study by Novak and others in 2024. And I would just say this. I think hereditary alpha tryptasemia does not appear at present to impact the autonomic system as robustly as MCAS does. So it's important to sort of separate the two, I think, in terms of that. I want to leave time for questions, and so I'd like to end there, and I'm happy to take any questions from the audience.
Okay, so I don't know that you're going to have answers to all these, but I think sometimes even the questions the community is asking is informative and teaches us like things we need to know and figure out with
Mhm.
future research. So here's a question. Well, there's a lot of questions from people asking for recommendations for mast cell savvy doctors. I think the best, unless, it's very hard, as Dr. Stino said, his clinic is not taking new patients at the moment. It's very hard to find doctors who are good at this. I think the best place to find that out is to ask on patient support groups. So Dysautonomia International has support groups in all 50 US states, all Canadian provinces, and in like 70 other countries around the world. So join those support groups if you go to dysautonomiainternational.org/support. They're free to join. And you go on, and every one of the groups has a peer recommended provider list. So that's doctors recommended by local patients who are in the area. But then you could specifically ask on the group, like, hey, who found a good mast cell doctor in Oklahoma? And people will tell you who they found, or that they couldn't find anyone. But that was a lot of the questions are similar. So I put those links in the answered questions on Zoom. There are some links to that. So we'll get to questions for you. Um, can you talk a little bit about what about people who don't have hereditary alpha tryptasemia, but they have chronically elevated tryptase? Do you see that? And what do you guys think of that?
Yeah, it's a great question. I think that I I forgot what Jem would tell me. I think from what I recall, when we were stratifying patients for the research study, which was very challenging because you're sort of having to look at their genetic status, whether or not they fulfill MCAS criteria above and beyond tryptosemia.
Mhm.
If I recall, and I don't want to misspeak, but I think it's rather rare to have tryptosemia without hereditary alpha tryptosemia. I think it's the minority of cases. Um, but I would have to double check. So please verify what I said because I don't know if that's for certain. But I would say, one thing that I would immediately think about is, well, maybe you actually have mast cell activation syndrome in that, the criteria is really that you have a 20, I believe it's a 120% elevation above and beyond your baseline tryptase, but during a flushing or anaphylactic event. So that may be the case, that it's sort of, but I would definitely consult an allergist for that specific substratification.
Yeah. So here's a more researchy question. I think it's a great question. I don't think that there's a great clinical answer for it yet, but it's a good talking point. Is there any way to figure out what pathway is triggering one's mast cells to degranulate? For example, can you figure out if it's IgE or autoantibodies or other ligands that are binding to the receptors?
Yeah, well, that's a great question again.
I think
I
it's a
wish
research
Jen,
study that needs to happen.
yeah, and I wish we had an allergist. I tried to get Dr. Aiken to join. He was unable to join, but yeah, I would just say in terms of the trigger or the pathway, I would not know the answer to that. But definitely, and sort of tying into the previous question, Lauren, I think I cannot overstate the importance of really working with an allergist because, again, I think having an allergist who's willing to listen, has an open mind, can really help pave the way to treatment of the mast cell disorder, the tryptasemia, and or downstream dysautonomic symptoms.
Yeah.
But I would just have to pass on that question because I don't know the answer. Apologize.
I'm gonna chime in a little bit, and I'm
Yeah,
not a clinician, but
yeah,
I'm a patient who had horrific mast cell stuff. Like, so it
yeah,
was landing me in the hospital all the time
yeah,
when this when before I kind of had a good doctor and a good treatment plan and everything, you know.
yeah.
So for the IgE, you can get standard IgE antibody testing for specific if there's like if you have a mast cell reaction every time you eat a banana,
Hmm.
you can get IgE antibody testing to see if you're allergic to bananas. IgE would be
Hmm.
like if you're allergic to bananas. So you can
Hmm.
do that. And like I think sometimes as dysautonomia patients, we hear so much it's mast cell, it's mast cell. And like some of us actually have just real IgE allergies, standard allergies, right? And I also think that maybe when you're more prone to this mast cell stuff, maybe you're sort of a more allergic person to begin with.
Hmm.
Because I developed new IgE mediated allergies
Hmm.
after the mast cell stuff, and I had Sjogren's and POTS, and
Hmm.
so I don't want to. I want people to be careful to jump to conclusions because when there's a lack of information as patients, we try to figure it out, right? And and it's so hard to find a doctor that knows this that a
Right.
lot of times we'll like people go, oh, like you see any rash in a photo on our support groups, and everyone's like, it's mast cell, like, but what if it's
Hmm.
lupus? Like
Hmm. Yeah.
think we got to be careful. It could be mast cell stuff, right? But
Hmm.
it could be other stuff. So, in terms of the antibodies, there's no like clinically, commercially like credible, reliable test right now for those adrenergic and muscarinic receptor antibodies. There are companies that do the testing, but it's the doctors don't think it's very credible. You can kind of spend your money and get a test, but it's not going to be used to change your clinical care.
Hmm.
But we have been funding research on those antibodies to try to find more clinically meaningful info about them. Like, could they be
Hmm.
used someday for clinical treatment decisions? We're not there yet.
Hmm.
And then the other ligands are, things that bind to receptors, right? And in the autonomic nervous system, the major ligand of the sympathetic nervous system is norepinephrine. And anybody who's like got a POTS or really any hyperadrenergic type dysautonomia where your sympathetic excess, you usually have a little bit too much norepinephrine flying around, right? And that does impact mast cells, right? It has an effect. If anybody, a good way to think about it, if anybody here has asthma and you had one of those, maybe I'm a little older, so I had the blue albuterol inhaler, right? I feel like in the 90s, like every kid had one of those. And that has albuterol acts like a norepinephrine, and it's actually working on the mast cells in your lungs and it's trying to get them, it's dilating and it's doing things to your lungs, it's doing things to your mast cells. So our autonomic problem that we have itself can drive mast cell problems. It's not even some people think of it as a one-way street. It's just the mast cells causing dysautonomia. It might, then other people think, well, maybe it's a two-way street. Maybe the mast cells are driving some dysautonomia, but the dysautonomia is driving some mast cells. But really, the way the immune system and the nervous system talks to each other is like this crazy, complicated overlapping. Like, those those movie scenes where there's like the crazy guy with the strings on the wall. Like that's kind of what it looks like if you try to
Yeah.
figure it out, right? So,
Yeah.
anyways, I'm sorry. I'll move on to the next question. I was just chiming in my 2 cents there. Somebody wanted to know, do you ever hear of people getting sort of joint pain that gets worse on antihistamines? And
Yeah.
if you
I've
can't use
not
antihistamines, are there other meds that are used?
yeah, I've not personally seen worsening of like arthralgias or joint pains on antihistaminergics. In terms of other medicines, again, I sort of would say, my armamentarium is sort of limited to what I was told or taught, H1 blockade, H2 blockade, whether you use, Allegra or fexofenadine or Zyrtec, really, secondary, H2, I'll often use famotidine. And then for, mast cell stabilization, again, a big sort of proponent of cromolyn sodium. Others, of course, have quercetin, ketotifen. And then the aspirin piece, again, this is sort of what I was taught, right? Do you need to have it or not? I think it's a separate question. But um, there have definitely been cases where I think IgE, directed therapies are very much in order. So the monoclonal directed treatments, and so that's where really allergy evaluation is key. Um, so I don't know if that answers the question, but I would definitely make sure to involve an allergist because then they can really optimize and maybe to the question earlier, direct it at the sort of underlying driver. Is it mainly driven by the mast cell profile, or to your point, Lauren, is there really a strong autonomic driver and you need sympatholysis, right? Like I love clonidine patch. I love sort of that sympatholytic effect.
I'm
And
going to ask you, can you, for the newbies here, can you
yeah,
explain sympatholytic, like what that means?
yes. Yes. So sorry.
Okay, I know what it means, and
Yeah.
I think a lot of our guests do, but
Yeah.
maybe some
So
newly
I
diagnosed
would
folks.
say you sort of think back, right, to that really cool paper in 2005 from the Vanderbilt group that they said a lot of patients that have the hyperadrenergic POTS picture, they
Mhm.
have concomitant underlying mast cell activation. And so it's sort of to the point brought up earlier, it's very much potentially bidirectional, right? The sympathetic overdrive is driving this, but also the mast cell is driving the dysautonomia. And so, it's not only that you have to start on the mast cell end of the spectrum to improve the dysautonomic disability. You could also think, okay, let me start on the sympathetic fight, flight, or freeze end of the spectrum and sort of blunt that fight, flight, or freeze, sort of calm it down, rev the engine down from, fifth gear to third gear. So, beta blockade is really good. I know there's been a lot of worry about using beta blockers in asthmatics, but I think for the most part, mast cell patients, right, if they don't have bad asthma, I still use a low dose 10 milligrams BID of a non-selective beta blocker like propranolol. But I really like clonidine transdermal patch. I do that once a week, and I think that patients really find a lot of relief in that. So that's kind of what I mean by sympatholytics. It kind
Yeah,
of blunts the sympathetic effect. Others have used benzodiazepines as well. I don't personally use it as much, but it does seem to have a lot of benefit. So,
yeah. Here's a question about so what can be done to minimize side effects after eating, like headaches, dizziness, abdominal cramps, etc. So I think there's two pieces to that. There's like mast cell eating problems, and there's just plain old dysautonomia,
mm.
blood flow stuff, right? So maybe you can touch on both.
Yeah, so I think one of the biggest things, and I think it was in that treatment table, but it's just food avoidance or food diary, right? And so I think that's where dedicated allergy testing is really important because the best treatment is just avoidance, right? And so you sort of think about those histamine-rich foods, avocados, tomatoes. Uh, I think alcohol can do it. Fermented foods, yogurt, certain foods can drive, but of course everyone is different. Um, and I think so that's number one. Here in Michigan, I get a lot of patients talking about black mold, right, being their major driver, or certain rooms in their home, or certain environments, or visiting, certain neighborhoods and certain tree driven allergies. So I think that the other sort of specific point to that postprandial, I've noticed sort of mast cell stabilization, specifically with cromolyn, seems to be very effective at sort of mitigating some of those explosive diarrhea or dyspepsia or postprandial abdominal pain. But again, I think working with a gastroenterologist can be really helpful to use other medications. Cyproheptadine can sometimes help, or Periactin, 4 milligrams 3 times a day. I know it's used to treat pediatric migraines, but I think it may also help with adult sort of not necessarily cyclic vomiting syndrome, but with this sort of maybe mast cell driven dyspepsia and migraine. So I sometimes use that as well.
Yeah. There was some interesting Vanderbilt research on um, glucose metabolism, and basically what their data showed is that when POTS patients, which I think you can expand the findings to broader or orthostatic intolerance kind of in general, they found that when POTS patients had carbohydrate intake, that they had excessive vasodilation in their abdominal blood vessels, which is where most of the blood pooling, a lot of us think the blood pooling is mostly happening in our legs,
Right.
but most of the blood pooling is actually happening in your abdominal area. You just might not notice it as much. And so when you eat, blood naturally goes to your gut to help your gut digest, right? But when you have an autonomic problem, you have too much vasodilation, too much blood pooling in the gut, which means not enough blood getting to your heart and brain, which sets off that big cascade of hyperadrenergic kind of, really unpleasant symptoms, lightheadedness, brain fog, fatigue. And so if you're, and it lasts a few hours after we eat carbohydrates. So if you're eating, oatmeal for breakfast, carbohydrates, and then you're having a sandwich for lunch, carbohydrates, and so the average person is eating carbohydrates all day long, and so what they recommend is actually not a no carbohydrate diet because that really wouldn't be healthy, but a low carbohydrate diet and focusing on complex carbohydrates like sweet potatoes and healthy vegetables, and not like bread, pasta, cookies kind of stuff.
Mhm.
And so also eating smaller meals might help reduce some of the post-eating symptoms, right?
Mhm.
And so that can actually happen in dysautonomia patients who don't even have mast cell stuff. That can just be a blood flow glucose kind of thing. But people with mast cell, if you're feeling worse after food, it might be the certain food you're eating is, your immune system is kind of getting a little revved up by it. So
Mhm. Mhm.
the other thing that I can had it happen really bad to myself, you can that when you have a mast cell reaction and you think it's like, oh, I think it's because I just ate that peach. And then you're like, oh, I'm afraid to eat peaches now, you know?
Mhm.
That keeps happening over and over again. You can end up on an extremely nutritionally deficient diet, right? And that happened to me. Like I had to go to an allergist and he put me on a chicken and rice diet for 3 months. And we added like one food at a time. And like half the foods I ate, I was like reacting to for no
Mhm.
particular reason. Like I didn't have an
Mhm.
actual allergy. So it's really
Yeah.
hard. And when you're already sick with some kind of dysautonomia or other illness, and then you're getting a lack of nutrition, you're just going to get sicker. So I
Mhm.
think it's super important if you're feeling like your diet is increasingly getting restricted because of your mast cell reactions. I think it's super important to work with a nutritionist or a dietitian to make sure that you're having at least a balanced diet, even if you have a small number of foods you can eat, that you're
Yes.
covering all the bases because you don't want to
Yes.
end up with a vitamin deficiency neuropathy on
Yes.
top of your dysautonomia,
Yeah,
right?
that's a huge point. I mean, I definitely pick up a lot of B12 deficiencies that have kind of been swept under the rug. So certainly.
Yeah. So here's another, there's so many great questions here. Um, let's see. So, let's see. Oh my gosh, I don't even, there's so many, I don't know what to ask. Okay. Someone is asking why a low gluten diet? Is that something that you suggested in your talk? I might have missed that.
I don't recall specifically suggesting it, but no, I don't know if I mean I don't recall mentioning it, but I would just say probably um I wouldn't go out and say you have to be on a gluten-free diet or a low gluten diet from what I'm aware of. I would just say the key thing is, at least from a mast cell standpoint, to develop a specific food diary for your body and to be aware of what can trigger flares because some patients will have very clear food triggered
Yeah.
flares. But as for the role of a gluten-free or low gluten diet, I wouldn't be able to comment on that specifically.
So there was a study out of, I believe, out of the UK showing that people with POTS had a higher rate of non-celiac gluten sensitivity.
Hmm.
So we've had on our website for years a sort of self-care tips, and we've said,
Hmm.
try a gluten-free diet and see if it helps you, but
Hmm.
don't stick with it unless it's really doing something different for you, right? You
Hmm.
don't want to have unnecessary food restrictions.
Right.
I do think sometimes people go gluten-free and it's helping, and it might be just because they're eating less carbs, you know.
Right.
But
Okay. Yeah.
nowadays there's so much gluten-free junk food that
Hmm.
it's easier to eat the carbs even though you're sticking
Hmm.
free. But
Right.
some people have actual celiac disease in our community.
Hmm.
Some people have the non-celiac gluten sensitivity, and some people
Hmm.
just do better on the lower carb stuff. So
Hmm.
I'm a big fan of it's a pretty benign thing to just try it
Hmm.
for like 2 months. And if you feel much better, then stick with it. And if you don't,
Hmm.
like go back to eating bread.
Certainly, yeah.
We said the same thing about dairy. Dr. Peter Rowe had said this years ago that quite a few of his dysautonomia patients are having the sort of immunological, GI symptoms and stuff. Just try dairy free for just like a few weeks to see if you feel any better, and stick with it if you do. Sometimes we don't know why something's helping, but
Hmm.
if you can get 10% better from this and 10% better from that, like maybe holistically, we can get you back to 60% better, something.
Hmm. Yep.
Okay, let's see some more questions. I think we'll just do like maybe like two or three more because I know we got to let you
Hmm.
go at some point. Um, do you ever see dysautonomy patients who don't have mast cell in the beginning but then develop it later on?
Yeah, it's a really good question. So, I wouldn't be surprised if it happens. I do diagnose patients with mast cell disease at times on repeat eval, possibly because I missed them the first time, or because their symptoms were not as manifest. So, one of the really good paradigms or pearls I know Dr. Brent Goodman would always sort of teach us and tell us is that the dysautonomic profile can evolve over time, right? And so it's not a static, hyperadrenergic or neuropathic or hypovolemic phenotype and it sticks. But it definitely, I could see a situation where, yes, it could evolve into mast cell later. And again, I think there is something unique about the profile, yeah, that this is disproportionately young women with an autoimmune profile. I think there's something about the role of stress triggering mast cells and triggering the immune system in women that's unique. And so I could certainly see stress at certain points in time hitting a patient who has dysautonomia and triggering mast cell activation.
I think I'm going to expand on what you said before people
Yeah.
start throwing tomatoes at us. So you don't mean just emotional stress, right? You mean emotional
No,
stress plus physical stress, like
right.
car accidents plus infection stress.
Yes, multiple stressors, not just,
Stress can
yeah.
mean a lot of different things.
Yes, yes. But
I
even
didn't want
just
anyone to think you were saying all of this is just caused by anxiety because they would not
no,
like
no, no. But
that.
even just emotional and psychological stress. I'm now just having done this for 10 years just in practice, I really see the physical and physiological impact of it. So I think it's
Mhm.
definitely a huge driver too. So
I think it's multi-factor. And it's
right,
also like if you're having all of these kind of frightening symptoms and
right,
it's hard to find a doctor to help you and you
right,
can't really figure out a treatment plan, it is emotionally taxing to live through that. And it's a bit of a trauma
right,
sometimes. And
right,
I think as patients, we don't want to talk about that because we don't want the doctor to say, well, the whole thing is just in your head.
right. No, no, no.
But
It's
I think if you're being good to yourself, you need to acknowledge if you are feeling like this is really emotionally overwhelming, living with all this
yeah,
scary stuff,
right, right,
getting some counseling for that to, they're not going to necessarily get rid of your symptoms, but sort of helping you
right.
process a grief sometimes, and helping you kind of map out your best coping skills pathway to kind of keep you moving forward. Um, so somebody says their mast cell burning symptoms, presumably on their skin, goes away when they use Benadryl spray. Have you heard of other people doing this?
I may have. I know that for clonidine transdermal patches, it's been a problem, the adhesive sensitivity reactions. I've had patients apply topical antihistaminergics. So I think it's actually really smart to consider that, to allow, for example, adhesives like clonidine transdermal patch or others. But yeah, I would say why not?
I have used Benadryl spray on the burning itchies. I had a
Yeah,
terminal ganglionitis that was causing patch on my face to be all burnt
yeah,
all the time. Also, Emla cream, which I had gotten for a chessboard at one point.
yeah.
It's a topical anesthetic. Like it's like a lidocaine, but it's a cream, right?
Hmm.
And that's a sodium channel blocker. But you shouldn't smear that all over your body because too
No,
much
no.
is a bad thing. But yeah, small. I also found, I don't know if I would love to hear from other patients, like your tips and tricks to deal with the mast cell symptoms. I'm like,
Hmm.
cold water, sometimes, although for some people, the cold water sets off hives, right? There's a subset of us that get the sort of
Yeah.
cholinergic dysautonomias. But ice cubes and cold water are good vasoconstrictors. And sometimes I think that that can help once you kind of get a reaction going. Even I used to just eat ice cubes sometimes. What else? Like, let's see. There's so many questions here. Oh my goodness. I can tell this is like a huge topic. We know. I think the problem is that most people can't find a doctor to help them on it.
Hmm. Hmm. And
Doctor.
if I could briefly just, because I feel bad. I know access is a major run. You thankfully, I mean, DI is doing huge work in sort of providing advocacy. I think what I've told patients in general is most important thing is find a point of entry, whatever the specialty, who's just willing to listen, has an open mind, is willing to, and I tell patients just use the language of the field. So if you go to the patient physician, say, I believe I have this, and it's not just a list of 500 symptoms, but the key points, because doctors are so pressed for time, and say, I may have this. I would just appreciate if you have an allergist in the community or someone who would be open, just the power of suggestion, right? So to look at my case and to see. And I find that, those physicians, whatever their specialty, who have an open mind and a willingness and are not dogmatic in the way they were trained, 40, 30 years ago, they at least open the possibility of getting to a diagnosis.
Mhm.
Because it's really the problem is when physicians and patients are just talking past each other, and then so that is just my suggestion, if access is a major issue.
It is, I think, for a lot of patients, so that's
Yeah.
helpful.
Yeah.